how is the age affecting the dislocation?
The shoulder is an innately unstable joint. Age is the most important factor which determines whether the shoulder dislocates again or not. The shoulder usually never dislocates in a child. When you do a close reduction maneuver, when you pull it back, when you rotate, it comes and falls into place.
There is a friction.
Yes, that causes the damage to the edge of the cup.
Yeah.
I was the person who did the metal-free lattice method first in South India,
Oh,
and
wow.
we have the largest
That's great.
series, and we got a special method of doing that without using metal screws.
Voices shaping the future of medicine. Stories, knowledge, experience. More for life.
Hello everyone. Today, Project Heal is here with an interesting topic. Probably you must have experienced yourself, or you must have seen or heard someone saying, "My shoulder just popped out and I just put it back." Maybe it is normal for you, but not for a doctor. So today, we have a special surgeon to tell us what exactly happens. So, welcome, Dr. Sujit.
Hello.
So, doctor, let us start with the question: why it is happening? The shoulder popping out.
Shoulder dislocation is not a very uncommon problem. The shoulder dislocates because of the tear or imbalance between the ligaments which hold the shoulder ball and cup together. The shoulder is an innately unstable joint. So it's like a golf ball on a tee. It's compared to a small tee and a ball sitting on it. So the cup is very narrow or very small, and the ball is very large. So it's very easy for it to topple off. And shoulder is a joint which has maximum movements. So the hip joint is almost similar to the shoulder joint, but the movement of the hip we have is very limited. But shoulder can go into 180 degree of flexion, and you can go into cross adduction, you can reach behind the back, rotate it outwards, you can throw. A lot of movements are in the shoulder. So for that purpose, the God has created, or the nature has created, the shoulder joint as a small cup and a large ball so that you can roll. So the stability is not on the bony congruity. The bones are very minimally in contact. So the connection between the ball and the cup is with ligaments which connect the ball to the cup. And when the shoulder is put into an extreme movement, that is when the ligaments tear. That ligament can tear most commonly from the edge of the cup or from the edge of the ball as well, which is a rare lesion called a Hagel lesion. Otherwise, it's called a Bankart lesion, where the ligament tears from the edge of the cup, and that tear may not heal in many people. I wouldn't say 100%, but then many of the people, the tear remains as such. It is when the tear remains like that, later on, when the shoulder is put into that particular movement, the shoulder dislocates again. So when the shoulder dislocates once, initially what is done is you give some traction, maybe some anesthesia, relax the muscles, and you do a maneuver by externally rotating and putting it back. It just locks into place. But that doesn't solve the issue. Like I said, some people say it pops out, but I'm able to put it back, and that solves the issue for them. But the people think that probably it is corrected as well. In like traditional treatment, that was the close reduction was only treatment available in one era. But now we have methods to correct that problem, to prevent that from happening, which are like keyhole procedures to correct it. And the recurrence of a dislocation happening again is usually related to multiple factors, including the age of the patient, or the functional abilities or requirement of the patient, and the condition of the ligaments and the ligament laxity.
Okay, doctor. So how is the age affecting the dislocation?
Yes, that's a very good question. Age is the most important factor which determines whether the shoulder dislocates again or not.
Okay.
So shoulder dislocation happens in two groups of patients. The very young, which is a common dislocation that we see, or the old as well, the older people above 60 years. So there are two peaks of shoulder dislocation. One peak is around 20s to 30s, and the second peak is around 60s. The second peak is not because of ligamentous injury. It is basically because of muscular problems. So in a younger person, like 20s, it's not the muscles, it's the ligaments, because muscles are very supple. So you can put the movement through lot of shoulder through lot of movements, but the muscles will still hold on. But for an older person, the ligaments are not that important because ligaments are hard, but the tendons have become thicker and firmer. So they tear sometimes and cause a dislocation due to tear of the rotator cuff tendons. So which is a different ball game. We are talking about the young dislocators.
Yeah.
So the younger the person is, that is around 20s, is when the tendon and the ligaments are very supple and soft.
Okay.
So they can tear and they may not heal properly. So yeah, a person, just like today in the afternoon, I was consulting a patient who was only 19, who had a dislocation 2 years earlier.
Oh.
And he had done a clause reduction, and then they went through a physiotherapy program for 2 years, and almost 6 months he was on a full rehab, and then he started sports. He was doing sports well for 2 years, and when it dislocated again. And now he has come with a bony lesion as well.
Oh.
When the shoulder dislocated, the edge of the cup also broke off. So there is a 10% bone loss. So bone loss is something which can complicate shoulder dislocation. So dislocation happen more in a very young person, like in the 20s or less than 20s. The chance of redislocation is almost like 95%.
Oh.
But for a person above 40 years, if it dislocates, or above 30 years if it dislocates, the chance of redislocation is only maybe 35 to 50%.
Okay.
So for an older person, like 30, 35, that is older for the shoulder dislocation sense,
Yeah.
the chance of redislocation is less, so you can treat them conservatively. You do a close reduction, do a good rehab, and then reassess them after 6 weeks and then 3 months. At 3 months, if the shoulder is not apprehensive, like how a doctor tests the shoulder stability is, you put the shoulder to that abduction external rotation maneuver and you give a thrust. Like the crank test or apprehension tests are there, or the Jobs test are there to check for stability of the shoulder. So when you do the test, when the shoulder is still feeling like it will pop out, that the fear of dislocation, when it's there, that means the shoulder is going to dislocate, or the ligaments might not have healed properly. So you subject them to a MRI scan, which tells you. You can see the ligaments on an MRI, whether it is torn, how big is the tear, from what o'clock to what o'clock position is the tear present. And depending on that, we can plan a treatment if it is unstable after 2 to 3 months for a 30-year-old or 40-year-old. But for a 20-year-old, it is almost sure that it is going to dislocate again.
Okay.
That's how it happens again, because the shoulder has gone out, means there is a big rent in the anterior part of the cup, which has not healed, which will probably not heal, and is going to dislocate again. So even one-time dislocation is an indication for correction of this problem, which is a very simple solution, simple keyhole procedure. You'll have just 2 puncture holes on the front and 1 on the back. You can go in with arthroscope, a keyhole instrument will go inside, and you repair this ligament back. With using anchors. So you have fiber anchors now, which are very much MRI compatible, and you don't see them on the X-ray. It's not metal at all, and it just goes like 1.5 or 1.8 millimeter small anchors go inside, and you have threads on that which are used to repair the ligament back. Like 2 or 3 anchors, 3 or 4 anchors are usually, minimum of 3 numbers is what we usually say for a tear in the anterior labrum to repair the ligament back. So age-wise, in an older person, as I initially said, if it's above 60%, it's usually a tendon tear, not a ligament tear. So tendon is the edge of the muscles attached to the bone, and they help to move the shoulder ball up. When that tendon tears from the edge of the bone, you can reattach it again by an arthroscopy, a keyhole procedure, to using anchors to fix the tendon back. That is an older person who dislocates. If the muscle power will be less. When you do the muscle power testing, like you do a resistance empty can test or a bear hug test and external rotation resistor test, you will have a weakness of that muscle, which will tell us that the muscle might have torn. Then we subject the patient to an MR, which will tell us what to do and repair the tendon back.
Okay, doctor. So you just mentioned that the first dislocation causes the damage to the shoulder joint, and age is one factor which tells us if it continues to dislocate or not. So are there any other factors that tells us if it is continue to dislocate?
Yes, ligament laxity is one of the reasons. So what I didn't say in the initial part was it can dislocate even without a ligament tear for some people. So like tall individuals, when the ligaments are lax, so there are people with loose ligaments, when the ligaments are very soft and very supple, too supple, when the collagen quality of the body is made in such a way that the collagen quality is weak, so that they are stretchable. So like the magician Houdini, people say he had a ligament laxity problem. That's how he used to dislocate his shoulders by himself and put it back. So that is not a traumatic dislocation. That is a multi-ligament laxity scenario. where the ligaments are loose. So when you pull the shoulder down, you can see like a sulcus forming here, and the ball can be pulled away from the cup and it can be put back. So that is a very difficult scenario to treat as well, because the innate quality of the ligament will be loose. So those individuals, we can do some tests. There is a scoring system for that to see if you are unstable or loose. Like you pull your little finger backwards. If you're able to push it backwards more than 90 degrees, that means you give a score of 1. You pull this back, a score of 2, more than 90 degrees. You are able to touch your thumb with the front of your forearm. That is again a score of 1. So 1, 2, 3, 4 with the other side. Elbow, when it's able to move backwards, hyperextend more than 20 degrees, you call it again another score. Knees, hyperextending backwards more than 30 degrees. And when you're able to touch the floor bending forwards with your palm. Yeah, many yoga people do that, yes, by training. But then when all these things are present, when you're able to touch the floor with your palm, again that is a score of 9. So any score above 6 or 5 can indicate that the ligament has, the patient has the ligament has laxity or a loose, or the quality of the ligaments may be not as good. So you may have to like treat them when you're doing a procedure. We may have to go for stronger procedures, or if it's just a ligament laxity without a tear, probably you can rehab and strengthen the muscles and give them stability and avoid certain activities like extreme movements and like contact sports, and those things probably can be restricted a bit to prevent a redislocation. And if it redislocates again, in spite of all these measures, you have methods again arthroscopically to tighten the capsule, called the capsular imbrication, where you tighten the ligaments and make them shorter so that it does not dislocate that easily. But then when the collagen quality is bad, there is again a risk of redislocation in that type of people. But for a traumatic dislocation, when it's torn from the edge of the cup, you are just reattaching back, you are restoring the person to normal. If there is no bone loss in the cup, again, there is another second factor I would like to say, when bone breaks off from the edge. So for a person for whom it dislocates multiple times, like a person who's popping out and putting it back, it happens 2 or 3 times. What happens is the edge of the cup becomes damaged, where that is a cup of the shoulder joint and that is a ball, and these are the ligaments which hold the cup to the ball. Okay? So when the dislocation happens, this tears from the edge of the cup and the ball goes forwards. Yeah. When this happens, the cup is like a flat disc and it narrows down underneath. So the ball goes and locks in this space. Yeah. So that's the reason you're not able to relocate it back. So when you do a close reduction maneuver, when you pull it back, when you rotate, it comes and falls into place.
There is a friction.
Yes. That causes the damage to the edge of the cup. The cup edge breaks off. Or the top of the ball gets rubbed off.
Every single time you do it, this is happening.
It can happen each time it dislocates or when the relocation is done. So relocation ideally should always be done under anesthesia or under sedation. You relax the muscles and you will not have so much of force to be applied. So when a forcefully relocation is done, but in many emergencies, the anesthesia or sedation facility may not be available. So the doctors are forced to do a relocation with a little bit of brutal force sometimes. So that causes more of Hill-Sachs lesion. That is a defect on the top of the ball or a bony lesion at the edge of the cup. So I had a patient, he was in his 40s, late 40s. He was a biker. He was riding from Palakkad when he fell down and dislocated his shoulder. He had later on we found out that he had a rotator tear as well. And he was taken to a hospital nearby where 2 doctors did a lot of forceful relocation maneuvers.
Must have been painful.
Yeah, it was terribly painful for him, but they couldn't relocate it.
Why?
Then because it was locked. They couldn't do it because the muscles and the ligaments were tightly holding the ball and the cup together. Then he was taken to another hospital where sedation was given and the shoulder ball was relocated, and he was brought to me 3 weeks later with the weakness of the shoulder. And the supraspinatus was torn, the anterior edge of the cup had broken off, there was a bony Bankart lesion. The Bankart is a lesion we call for the tear of the ligament from the edge of the cup. When a bony piece breaks off, we call it a bony Bankart, when the bone piece is also associated with a Hill-Sachs lesion, where the top part of the ball is having a depression here. So we plan the treatment depending on how much bone loss or a bone fragment is there. But for a recurrent dislocator who has more than 4 or 5 dislocations, usually a bone piece may not be there. It's attrition, like it's rubbing off. So the bone will be lost. So that was another thing I was alluding to, like a loss of the glenoid. So when the bone loss is there of more than 10%, that itself is a bad scenario, which can cause redislocation even after a Bankart procedure. So, Bankart is the arthroscopic reattachment. So, Bankart procedure can fail if the bone loss is more than 10% in a 20-year-old or more than 20% in a 30-year-old. Yes. So, the bone has to be addressed. That is, I saying significant bone loss is usually above 25 or about 20% for any age. For a younger person, like 20s, in the 20s or 15 to 25 age group, 10% bone loss is also significant. So when the bone loss is there, you have to address the bone loss as well, not the labral tear. Because if you reattach the labrum with a bad bone, it can again redislocate very easily. The labrum repair can fail. It can tear off.
Okay.
So again, to answer your question, how to address the bone loss, we have methods to address the Hill-Sachs lesion, the humeral bone loss, by doing another additional procedure along with the Bankart repair, something called a remplissage.
Okay.
So the remplissage is a French term for filling in. That is, by arthroscopy, in the defect, you insert an anchor and you tie the infraspinatus tendon on the top here into that defect, so that the defect is prevented from engaging on the front of the cup where there is a lesion.
Okay, no more.
That's a remplissage. So that engagement will not happen.
Yeah.
If the bone loss is on the glenoid side, you can recreate the glenoid bone loss by methods. Multiple methods are there, of which the strongest procedure is a Latarjet procedure. Again, it's a French term where these type of contact sports, rugby and those type of sports are very common in Europe. So where these procedures are designed to give maximum stability to the shoulder. So the bone loss can be recreated using another bone in the shoulder, near the shoulder, called the coracoid bone. And this bone has the advantage that it's got a tendon attached to it called the conjoint tendon, which is one part of the biceps, the short of the biceps attaches there at the coracoid bone, and that can be used to give stability to the shoulder joint. So in addition to the labral continuity that you're going to create, you can take this coracoid, make a split in the muscle in the front called the subscapularis. That's the subscapularis.
Okay.
The anterior bone loss can be recreated using this coracoid bone with an attached tendon, which is supposed to be the strongest method for bony reconstruction of the glenoid. Why? Because it's not just the bone piece you're going to keep there on the front of the shoulder of the glenoid. You're making a split in the subscapularis tendon in the front, and this is brought inside the shoulder, and it will have an attached tendon in front.
Yeah.
So when the shoulder is put into that Aber maneuver, it is not just the weak capsule which is already torn and reattached. You'll have this tendon also in front of the shoulder, which will prevent the shoulder ball from popping out.
Okay.
So that gives the maximum stability of all the procedures available.
Yeah.
Then there is a simpler method of giving bone reconstruction, where you take a bone piece from either the iliac crest, that is your hip bone where there is a lot of extra bone in your body, or the scapular spine or the distal clavicle. These are three areas where you can take, or an allograft from outside bone can be taken to reconstruct this bone. But there you are only recreating a bone piece, not this extra tendinous attachment, which will give extra stability to the shoulder. So Latarjet is supposed to be the strongest procedure for bone loss.
Okay, doctor.
And it can be done arthroscopically. And ours is a center which has a maximum number of arthroscopic Latarjets in South India.
Yeah.
I was the person who did the metal-free Latarjet method first in South India.
Oh,
and
wow.
we have the
That's
largest
great.
series, and we got a special method of doing that without using metal screws.
Oh, that's nice.
So explaining on that, the Latarjet can be done by two methods, either using metal screws, which is a traditional method, where open surgery was described by Michael Latarjet, a French surgeon, who designed this procedure, described this procedure in 1980s, where a piece of bone with the conjoint tendon was taken, and incision was made on the front of the shoulder, and it was attached using two metal screws. And this was made arthroscopic by another surgeon in France called Lafosse, who described an arthroscopic method of doing this, the keyhole method of doing this Latarjet procedure using metal screws. And that was again changed by surgeons around the world. Like Abdullah Hakim is another person in Spain, Barcelona, who's designed this cerclage tape to do it. And I have made a modification to that using something called a buckler, which is a protector or a shield to the coracoid. Why? Because the coracoid is a very soft bone. And the advantage is that when you use the coracoid to recreate anterior glenoid, the coracoid remodels very well. So it remodels to the shape of the original coracoid, unlike the bone taken from the iliac crest or the scapular spine, which are hard bone. The soft bone has the advantage that it becomes almost like the normal glenoid. If you take a CT scan or an X-ray after a year, it looks almost like the original glenoid, even with 20% or 25 or 30% bone loss. It can be recreated.
Okay.
But the problem is when you use a cerclage tape, the tape is very strong. It's like a metal wire cutting through. So when you tension the tape, it goes from the back and tensions it, and it is stronger than metal screws, but it can cut through the coracoid. So that was a disadvantage for metal-free. And then this metal-free cerclage tape method was made more acceptable and safer by using the buckler, which we have published, and we are in the process of bringing out the series. And I've got the largest series of that, doing a latter J using a buckler and a cerclage tape, which gives bony stability in a metal-free manner. So you take an X-ray, it looks like a normal shoulder. Only a trained eye can detect that the bone piece has been created on the front, and it gives a problem-free recovery to the patient.
Okay. So, doctor, you just mentioned a couple of procedures. So, which one would you suggest to people, or what is the success rate of each procedure, and what might be the complexities that might come when you do a surgery?
Yes. So, arthroscopic surgery has a learning curve. The surgeon has to be trained well in doing a keyhole procedure. So, but the advantage of a keyhole procedure is that you are inside the shoulder joint. You can move around and do all the corrective procedures required for the shoulder. In open procedure, you'll have an incision, but you can have a vision of only the front part of the shoulder joint through an open incision. The back of the shoulder, like the Hill-Sachs lesion I was talking about, is totally away from your view.
Yeah.
So in arthroscopy, you have a portal on the back, two portals on the front. In a latter G, we'll have one more portal on the side to view and stuff like that. And when you do an arthroscopic procedure, you can repair the labrum. You can reattach the bony fragment like the coracoid or the bone piece they are going to use in the front, and the labrum can be reattached. So the ball will have a very soft surface to roll, and the remplissage also can be done along with that. And labral tears can be repaired on the top of the shoulder, the front of the shoulder, and the back of the shoulder if there is. Like there are people with a pan-labral or extension of the labral tear. The Bankart lesion can extend to the top of the shoulder, on the back of the shoulder. So all those can be corrected by an arthroscopic procedure. And the Bankart procedure has a very high success rate. Like if the indication should be right, the patient selection and the treatment selection for that particular age of the patient, as we already discussed, the patient's age is a very important factor. So all those are considered and correctly executed, the redislocation rate is very, very low. But for a patient with a bone loss over 20%, if a keyhole Bankart procedure alone is done, the redislocation chance is very high.
Okay.
Especially if the age is less.
Yeah.
For a person older than 40 years or 35 years, if you do a Bankart procedure for a bone loss of 20%, he may be stable, but he will be apprehensive. So Bankart with remplissage will give probably a dislocation-free shoulder, but he won't be happy enough to do an ABER maneuver, abduction external rotation maneuver, or throwing movement. He'll be afraid. So he will probably not go back to his sport.
Yeah.
Because he'll be protecting, he'll change his sport.
Yeah.
Because he's not confident with the shoulder. But you give a bony support when you expand the cup more and you give more support on the front with a conjoint tendon, the confidence of the patient to do that type of movement will be more.
Will
So
they be experiencing pain?
pain absolutely will not be there.
Okay.
The procedure is just a 1 hour procedure. A Bankart is very simple. I take only 45 minutes for a Bankart.
No.
You insert anchors and ties. It's a small simple procedure.
Post-surgery?
Post-surgery, the first day there will be some discomfort.
Yeah.
In one day, mostly the patients can go home. 24 hours is all that is required. Sometimes they stay for a day more, that's just for comfort and getting some movements. In 2 days' time, most of the patients are very, very comfortable. There won't be pain at all because it's just a keyhole procedure. Pain is all usually from the skin. And bony drilling is only 1.8 millimeters. So that also will go off in a day's time. And in 2 days' time or 3 days' time, they can start usually working. like a software or a computer person who's working in the office, they usually start working in 4 or 5 days time, because they can use use the hand in the frontal plane. Avoid this Aber maneuver for 5-6 weeks. That is until the healing is complete.
Yeah.
Like in the body space, they can use the hand from the head, combing of the hair, feeding, cleaning, and eating food, and normal things can be done in 2-3 days time. In 4-5 days time, they are usually doing everything, maybe including driving they can do without doing this abduction external rotation maneuver. There is no need for a sling for a bank cut.
Yeah.
So in olden days, we used to give a sling for 6 weeks. That is not required for a bank cut. So we say, as long as the patient is sitting consciously, in sleep you use a sling, because you don't know how you're going to keep the hand. If you are a prone sleeper, a tummy sleeper, you may keep the hand like that. So that can cause a re-tear, or healing tendon can be torn again. But when you're consciously sitting on a chair or driving a vehicle, you don't need a sling at all. You can do a normal activity. And in 6 weeks' time, they can start moving the hand into external rotation and strengthen the shoulder. The shoulder, any joint which has an injury becomes weak. The muscles become weaker. So you strengthen the muscles over a period of time.
By physio?
By physiotherapy, yes. Exercises, basically strengthening.
Yeah.
So you do resistance training. Initially in 6 weeks, we give some resistance bands. Then we progress to weights. And in 6 months' time, the shoulder should be strong enough to do throwing and heavier activities. By the time the healing will be complete. For a latter J, the recovery is actually even faster, because it's a bony procedure. So the bone-to-bone healing is better than tendon-to-bone or ligament-to-bone healing.
Yeah.
So you can give faster activities. It all depends on what all procedures are you doing. If you're doing a labral repair, you follow the Bankart protocol. We have different protocols for different procedures. So if it's a bony procedure, you allow movements almost immediately. Again, no sling is required. If you use a sling, the shoulder becomes stiffer. So you allow the movement up to 90 degrees almost immediately. In 3 weeks' time, you start 20 degree more external rotation. In 6 weeks' time, full external rotation should be attained. Then you start strengthening. If you follow the protocol correctly, the recovery will be very smooth, and most of the patients are very happy in 3 months' time doing almost all activities. There are a lot of people who are doing active sports after maybe 6 months or 1 year.
Okay, doctor. So while we're talking about physio, when a shoulder dislocation happens, initially we go for physio, then it is not working out, then we go for surgery. Is that the case?
Yes, physiotherapy, what is physio? It's basically movements and strengthening.
Yeah.
And the proprioceptive sense, and then the plyometrics, all those things come in physiotherapy.
Yeah.
So initially, it is basically preventing a stiffness. So the shoulder dislocates, you put it back by the maneuvers we discussed. Then you start strengthening the muscles or mobilizing the joint and gain movements in the first 5-6 weeks. No strengthening usually in the 5-6 weeks. Then you start strengthening the muscles with various devices that we have. So the shoulder is a complex joint.
Yeah.
So it's got an inner set of muscles called the rotator cuff, as I said, the inner muscles, and the outer muscles which we see, the deltoid, the pectorals, the trapezii, the latissimus, serratus. All these muscles work together for the shoulder to move. So the initial abduction of the shoulder is with the rotator cuff. So first 20 degrees, the rotator cuff works. So initially we start every strengthening of the shoulder with the rotator cuff strengthening. Because if you start strengthening the outer muscles when the rotator cuff is weak, the shoulder gets compressed, or the shoulder ball and the arch above gets compressed. If that is the model, when the deltoid works, it will press the shoulder ball against the arch. That causes impingement pain. So always you start with inner muscle strengthenings, with the rotator cuff strengthening with therabands.
Yeah.
So the bands work in the lower plane. If you lift a weight, the weight starts working after 20 degrees. So that will only strengthen the outer muscles usually. So that is the science behind doing the therabands first. There are different colors of elastic bands. You start with maybe a red or green or blue, black, silver, gold. These are all the colors available. And you start with a lower band and progress. As you progress, you add weights also. And initially you start with the movements in the frontal plane, not the sideways. The deltoid is strengthened last. The deltoid can be a cause of shoulder pain. I had a gym trainer. He owns a gym in northern, part of Ernakulam, and he has a huge deltoids. So he deadlifts some 200 kilos. He does this fishing, like heavy, like fishing and all those heavy stuff. But he's got severe pain in the shoulder because of impingement. Because his deltoid is stronger than the rotator cuff. So the rotator cuff is getting impinged every time. It's like a crushing thing which works like a Hulk working on a small kid. So the rotator cuff is ignored mainly, or rotator cuff doesn't get strengthened if you do heavy lifting for the outer muscles. So you have to work on both the set of muscles. Especially for a rotator cuff tear rehabilitation, I always insist on strengthening in the lower planes initially, and then gradually progress to the outer muscles. If you go in that order, the shoulder usually functions quite well without an impingement and pain.
Okay, doctor. So, when it comes to shoulder dislocation, when it happens for a first time for a person, should they consult a doctor immediately after that, or at what point, or when, at what symptom should they consult a doctor?
It's a very pertinent question, because that's a confusion which many athletes have. Shoulder dislocation, as I said, happens like a ligament injury inside the knee joint. Dislocation is the next common injury that happens. And in the first instance, if the shoulder comes back into place by some maneuvers, some lighter maneuvers, or with a little sedation, if you're able to put it back, I would suggest always wait for some time. And especially, as I said, age is a criteria. Less than 20, it is better to consult a doctor maybe after a couple of weeks. Or if you're above 30, wait for some time, 2-3 months, and then test the shoulder. You do this maneuver and see if you're okay. Or go to a doctor and make him or her do a maneuver where you push the shoulder ball forwards in a controlled fashion and see. Because why I said a controlled fashion, the shoulder can dislocate again if you do a maneuver by an untrained person. Because I've seen shoulders dislocate in front of me.
Yeah. Oh.
Because I had a patient who had dislocated 30 times.
Oh my God.
He came to me for a problem, and he was telling me this happens, and he dislocated in front of me.
Oh.
And he couldn't put it back. Because
Oh
he was
God.
so apprehensive, the muscles contracted.
Oh.
And then we had to sedate him and relax him,
That's
and
worse.
then put the shoulder back. So, for a person who dislocates first time, more than 30, give it time. Maybe
Okay.
3 months time, reassess the stability, and then plan a treatment if required.
So, doctor, when continuous dislocation happens, what is the worst case that we can expect? What worse could happen?
Yes, I've had people who say they sleep with their arm tied to their chest,
Okay.
because they are not able to sleep because of fear of dislocation.
Oh.
Yeah, and that is the worst thing that can happen.
Okay.
Because their whole day can be affected if sleep is not proper. So that happens when there is bone loss. If you're able to put the shoulder back, that indicates bone loss, significant bone loss. Because only when the bone loss is more, like in subsequent dislocations, the ability to relocate will be more. When the ball dislocates and locks there, that means the bone loss is not much. But when it's coming back, that means the edge of the cup is worn off more, and the ball also has a bigger lesion. So the bone defects are allowing the cup and ball to relocate fast. And that is a bad sign. When you dislocate in the sleep, or you relocate very easily, that means the bone is worn off more than 20% or 25%. So we do tests. So how do you find out the bone loss is there or not? So X-ray can give you an idea whether there is a bone loss. MRI also can give you an idea whether there is a bone loss or not. In X-rays, we take X-rays of both the shoulders. We call them Bernagio views, where you take an X-ray of the shoulder cup. In the front and the back of the cup can be seen. The glenoid anti-reds can be seen in a Bernagio view. If it looks different from the other shoulder, unless the other shoulder is also dislocated. I've had bilateral shoulder dislocators. So one side, if the bone loss is more, on the Bernagio view, on the MRI, you can see the hill sacks. You can measure the hill sacks very clearly on MRI. But glenoid bone loss, I always insist on a CT scan. CT is very important to find out the amount of bone loss, because you can reconstruct the bones on a CT scan. You can see the bones just like that. Okay, you can minus all the muscles, and the bone can be exactly seen. The roundness of the cup can be recreated, and there is no chance that you will go wrong. On an MRI, if you measure, there might be many variables, and you're depending on a radiographer or a radiologist who is doing the measurements for you and giving you the idea. But on a 3D CT, you cannot go wrong, because the visual impression is there, whether the glenoid is pear-shaped or an inverted pear shape. So pear shape is this: the lower part of the glenoid is round and upper part is small. It's like a pear. So when there is bone loss, this much bone is lost, you call it an inverted pear. So the upper part will be wider and the lower part will be narrower. That's an inverted pear-shaped glenoid. So that can be seen very well, and the measurements can be accurately done on a CT scan, which will give you to the point millimeter by millimeter measurements, which will help you plan a treatment and prevent failures.
So, sir, previously you mentioned about Banker's tear progressing upwards.
Yes.
So, can you explain on that?
Yes, that is called a slab tear or a superior-labral antero-posterior tear. That is superior labrum. Bankart is an antero-inferior labral problem. That is, the inferior part is tearing. In superior labrum, you have the attachment of the biceps long head. That biceps, I said, it has a short head and a long head. Long head gives stability to the shoulder in above head movements. When the short head attaches on the top of the glenoid or the cup of the shoulder. There, if a tear happens, or it can happen de novo, there alone without a Bankart tear, or the Bankart tear can extend all the way up to the superior labrum, or the other way around. This happens first, and then the Bankart tear can happen. That usually happens due to a throwing maneuver in a throwing athlete.
Yeah.
The biceps can pull the superior labrum. Along with the longer the biceps, it can cause a tear. There will be significant weakness and pain in the shoulder, discomfort, especially overhead activities.
Yeah.
So that can be tested by an O'Brien's maneuver. That is, you cross the arm towards the opposite side of the body and make a thumbs down maneuver, and you give pressure.
Okay.
If that is weak or causes pain at the top of the shoulder, you have to understand there might be something with the superior labrum. Or it can be an acromioclavicular joint pathology. There are methods. You can externally rotate and then do the same maneuver if the pain disappears, and all those things are there. But then superior labrum causes weakness in that maneuver. If that is positive, those are the tests that we do. In addition to the apprehension test, the Job's test, you do an O'Brien always to see if the labral tear has extended superiorly. And that can again be corrected by arthroscopic procedures, keyhole procedures, if it is a bigger slab tear. A smaller slab tear, if it happens, you see on the MRI a small fraying, it can be left alone. It may heal by itself. But if it is a bigger tear, if it's detached from the superior labrum, there are methods to reattach it back, or a biceps tenodesis can be done for an older patient when the biceps has been torn for some time and it is degenerated. You do something called a tenodesis. That is, you fix the longer biceps somewhere else or out of the groove where the degeneration is over, so that pain may not be there, especially in older people. Like older than 40s, you usually go for a tenodesis. For a younger person, you repair the labrum. And the superior labral tears can cause another nasty problem, where the joint fluid inside the shoulder can gravitate out of the shoulder and form a cyst.
Okay.
So in the MRI, you can see a whitish fluid collection on the top or back of the shoulder, and that can cause nerve compressions.
Okay.
So I was just discussing with a patient today who had labral tears on both his shoulders with big cysts which have formed, like 2.5 to 3 centimeter cysts have formed. One in the inferior part, which is near the axillary nerve, another one on the top of the shoulder on the back, compressing the suprascapular nerve. So there is a notch in the back of the shoulder called the spinoglenoid notch, where this is the suprascapular notch through which the nerve comes out. So from the brachial plexus into the shoulder, supplying the two muscles here, the supraspinatus and infraspinatus, and it passes through the area here called the spinoglenoid notch into the infraspinatus fossa. So when the nerve gets compressed here, when the labral tear, the superior labral tear happens somewhere here, when a cyst forms here, it can compress the nerve and cause weakness of external rotational load.
Okay.
So when the rotator cuff is torn in an older person, you will have weakness of lifting as well as external rotation. When you give a resistance, there will be a weakness. But isolated external rotation weakness. When you do a resisted external rotation, that will be weak. Other side will be normal. When you see that, always suspect a spinoglenoid notch ganglion or a cyst, which is due to a degeneration or degenerative fluid leaking out from the joint causing this. So there again, you can decompress the cyst by arthroscopy and reattach the labrum back by using anchors and prevent the cyst from forming again.
Okay, doctor. So after post-surgery or post-treatment, is there any diet they should take, or are there any nutrition they should have?
These are ligaments and tendons we are reattaching. So ligaments cannot be strengthened by any method. All the protein or carbohydrate or nutrients you give are for the muscles mainly, maybe for bone strength, calciums and vitamin D and stuff like that. But ligaments have an innate quality of their own when you are growing or when you are born. So that is what nature gives you by your heredity and the factors like strengthening and stress that you give. So the nutrition has a role, definitely, but an indirect role, not a direct
Okay.
role. And for a younger person who is in his 20s, or he or she is in the 20s, a balanced diet is all that I usually advise.
Yeah.
An extra nutrient will not go there and make a healing. Even medications have very minimal role. Maybe
Okay.
collagen can have some role, vitamin D supplementation when it's low can have some role, but it's basically a mechanical problem which has to be corrected by a mechanical method.
Okay.
It's like a tear in a shirt. You stitch it in time, it doesn't progress. If it doesn't, if you don't stitch it, it becomes bigger and bigger over time. It becomes a nasty problem later to correct. So a stitch in time can probably save 9. So correct it early, you can probably prevent the problem from progressing more into a bony problem and going for a bony procedure, and all those stuff can be avoided if a smaller problem can be detected early and treated in time.
Okay, doctor. So, for the viewers watching this, what could be your short answer when my shoulder is popping out? What is exactly happening, or what should I do next?
Yeah. When the shoulder pops out, understand that there is a ligament tear which has happened, and you can wait for some time to heal, for that to heal, and try to test the shoulder to find out whether signs of instability are there, and don't allow the shoulder to dislocate again. The second time dislocation can cause bone loss. If you dislocate third time, there's a bigger problem. Don't allow the shoulder to dislocate more than once, and maybe more than twice. If it happens twice, get help, get it corrected. It can very well be corrected, and it can be restored to maybe 99 or 100% of your activities if it's properly diagnosed and treated.
So, I hope everything is clear for the viewers now. So, thank you so much, sir, for joining. It was wonderful talking to you. Thank you so much.
You're welcome.